Good morning, everybody. It's a real pleasure to be here. And as I was thinking about this session today, um, what was bothering me about it crystallized. And it is that when we think about health literacy, we think about literacy challenges among our patients and their families. But actually, the literacy problem rests with us. And what this roundtable, I hope, will demonstrate is that the failure to communicate here really rests with the health system. The obligation to be literate in what matters most to patients and families is ours. It is not their obligation to be literate about our culture. So I hope that today's presentations will bring that point home in a number of different ways, and I left the clicker over there. So I have no conflicts of interest to report. What I'm going to talk about today is the case for integrating palliative care principles and practices across the whole spectrum of healthcare for anybody with a serious illness. I want to talk about where the literacy problem actually originates in the context of healthcare and what we need to do to become literate in the needs and priorities of people with serious illness and of their families. Everyone, I'm sure, has seen these data on the extreme concentration of risk and spending in the healthcare system. Not surprisingly, the sickest patients are the costliest, as they should be. We shouldn't be spending a lot of money on healthy people. So I get very nervous when people start talking about all the waste on care of the seriously ill or waste in care of the dying. We don't know who's dying till after they died. And spending money on very sick people is not waste. How we spend that money is a different question. But that conflation of high spending with waste really should be eliminated. What this slide shows is that 1% of the sickest, most vulnerable patients account for a quarter of all spending, 5% for half of all spending. So even if you weren't particularly interested in the care of this subset, this small subset of US citizens, you would have to be interested based on how much they're costing. And because of that concentration of risk and spending and the data on the impact of palliative care on both quality in the numerator of the value equation and cost in the denominator, the principles and practices of palliative care are crucial to any effort to improve value in the US health system. So I want to talk about illiterate health systems first. And I'll tell you a story of one of our patients. This is Mr. and Mrs. B. This was taken at their 60th wedding anniversary party after 2 years or 18 months after I met him. As you can see, Mrs. B sews all her own clothing. She always makes a matching tie for Mr. B. She is a character. So I met him, what is now 2 years ago or a bit more, when he was 88. Was called down to the ED by one of my colleagues who said, Diane, I don't know if this is appropriate for me to call you because this patient is not dying. Problem. But this couple is abusing the emergency room. That was the terminology. This couple is abusing the emergency room for low back pain. Okay. So I went down with my medical student. It was about 6:30 on a Thursday evening. Patient described his back pain as terrible. His wife gave it an 8 out of 10. He was taking toxic doses of Tylenol, enough extra strength Tylenol to destroy his liver, like 2 extra strength Tylenol every 3 or 4 hours around the clock with no benefit. But having been told by his doctor that that was safe for him to take, he was just popping it. Why the attending in the ED said that this couple was abusing the emergency room is because this was his 4th ER visit in 3 months for similar problems. Back pain, inability to get up, falls, altered mental status and confusion that turned out to be due to a fecal impaction, constipation, and his wife at his bedside was in tears because he was absolutely furious at her. Why did you call them? I told you I don't want to go back to the ER. Let's go home. And here's what she said. He hates being in the hospital, but what could I do? The pain was terrible. I couldn't reach the doctor. So she did try. It was about 6 p.m. Mr. B had gone to the bathroom after dinner, had been unable to stand up from the toilet because his back was in spasm. She couldn't pull him up. And when she tried, he shoved her away and screamed at her. So she called the doctor's office. It was 6 o'clock. What did she get? What did the tape say? If this is a medical emergency, hang up now and call 911. Who's illiterate? Okay. She did exactly as she was told because it was a medical emergency. She couldn't move him. There was no one to help. So I called the ambulance. It was the only thing I could do. Yet the perspective on the side of our culture is that this couple is abusing the emergency room. Okay. So this is what happened, the usual care culture, before we were fortuitously and accidentally called to the ED on the fourth time. 4 911 calls in a 3-month period, 4 ambulance rides to the ED, 3 hospitalizations from the prior calls, leading to a hospital-acquired urinary tract infection because, of course, at that time, we were still putting Foley catheters in everybody in the emergency room. So, of course, he got a urinary tract infection and he became septic. Had a massive functional and cognitive decline just from being in the hospital with all the complications. Enormous family distress. So why did we get called to the ED that night? Pure accident, not because of any system design, not because of any intent to improve quality for people like this, but because the ED attending happened to have been a medical student at Mount Sinai years earlier and had spent 1 week on a mandatory rotation with our service, with me, as it happened. So it was pure accident, not by design, that this happened. Obviously, this should happen by design, not by accident. So we went downstairs, me and the student, spent really a long time with Mr. and Mrs. B, assessing the situation, asking what was going on, and decided to try him on ultra-low dose morphine to see what it did for his back pain. So fortunately, we have a pharmacy across the street at Mount Sinai that carries these drugs, which is not common. Again, health system illiteracy. Sent the student across the street to fill a prescription for concentrated liquid morphine that you can pull up in a syringe so you can give really low doses, and a Miralax box, which is a laxative. And he brought them back. In the meantime, we had given him a minute dose of morphine, 2.5 milligrams, which did not cause him to pass out or become crazy or fall. In fact, his face relaxed. He became much more cheerful, much more interactive. So he was tolerating it okay. We walked him to the bathroom. He was tolerating it. But what we spent most of our time with was Mrs. B, teaching her how to pull up the exact right amount of morphine in the syringe, teaching her how to mix the Miralax in water, how much to put in, how often to give it, writing everything out in block capital letters, and asking her to tell us back using teach back method what we had said. It took 3 efforts before we were clear enough that I was convinced she knew what to do, that we were not clear enough. Okay. Fortunately, I'm connected these days, so I'm connected to the director of our house calls program. It's called Visiting Doctors at Mount Sinai, and I just called her at 8 o'clock on her cell phone and said, this patient needs to be seen tomorrow morning. I am sending an 88-year-old with dementia and an 83-year-old family caregiver home on morphine. Somebody needs to be there tomorrow morning. So they did. And what they found was a disaster waiting to happen. Loose throw rugs everywhere, electrical wires crisscrossing the floor, no grab bars in the bathroom, no elevated toilet seat, and the only food in the refrigerator was leftover Chinese. Now, why was that? She could not go out to go grocery shopping because she could not leave him alone. He would freak out and either try to follow her or fall in trying to follow her. So she couldn't leave, and she didn't have a computer and didn't know how to order from Fresh Direct. So she did have a phone, so she called the Chinese restaurant next door. That's all that was in their refrigerator. So that home visit was sort of key to identifying what the issues were. So we connected him to the house calls program. It turned out they were members of a church that they hadn't been able to go to because he couldn't get there. When he stopped going, the pastor had turned over, so no one noticed that they weren't going to church because it was a new pastor. With their permission, we called. And the new pastor was very embarrassed that this miss had occurred. And of course, they have a friendly visitor program that hadn't been connected to Mr. and Mrs. B. And 3 afternoons a week now, a member of the congregation or a high school student on community service goes to the house, spends a few hours with Mr. B. Mrs. B gets out with her friends, can go shopping. If we did anything, that is probably the most important thing that we did. We organized Meals on Wheels. We called the daughter, who of course lives in California. All New York daughters live in California. They just get as far away as possible. But she has a computer, and she orders groceries online once a week now, and also visits a lot more often. We have the friendly visitor program. That was 2 years ago. He's doing fine. They have not once been back to the ER or the hospital. Now remember the value equation. Quality in the numerator, cost in the denominator. The usual way on the left, very, very low value, harmful to the patient, hugely expensive, but very typical and still the standard of practice in most parts of the country. And what is really hard to get on the right, obviously much higher quality, dramatically lower cost. Okay. So is Mr. B's experience atypical? It is not. These are data from Alex Smith at University of California, San Francisco, finding that 75% of older Americans are in an emergency department at least once during their last 6 months of life. Why? Because there is, as Mrs. B said, no alternative. Where's the illiteracy here? Who are these patients? They are not your typical end-stage cancer. They are not mostly disease-driven. They are mostly condition-driven. Mr. B does not have heart failure, cancer, COPD, end-stage renal disease. He's frail. He's cognitively impaired. He's functionally impaired. That's what's driving his utilization. Caregiver exhaustion. These are the criteria we should be screening for and targeting people with these issues. That he could have a serious illness. He doesn't yet. He's got being old. So the data supports this. These are Medicare current beneficiary survey data that show that 61% of the top 5% of spenders are functionally impaired. So if there was just a single factor you needed to start to segment and target the high-risk population, it would be functional status. Yet our EPIC charts do not require documentation of functional status, neither does Cerner. I mean, the most important variable that would be so simple is not recorded in the electronic health record. Dementia, very clearly a major predictor of risk and spending, and what these data do is compare Medicare utilization in community-dwelling older people with and without dementia. This is from the University of Indiana, from Chris Callahan, and you can see it yourself, but the Medicare and Medicaid utilization in otherwise comparable groups, only different because of cognitive impairment, is a multiplier in the dementia group. Why is it? What is it about dementia that leads to such high utilization? Anybody? Caregiver exhaustion. Caregiver exhaustion. Where's the illiteracy? And these are data from Betsy Bradley. She recently published a book on this topic. This is from BMJ Quality and Safety, showing the very low ratio of medical to social spending in the United States compared to other developed nations where, for example, Poland, Italy, Germany, Denmark, Belgium, Sweden spend about $2.70 on social supports for every dollar they spend on medical care. We spend 70 cents on social supports for every dollar we spend on medical care. Hence the dementia data. Hospitals are a substitute for absent social supports. Oh, yeah, that's us, the blue arrow. And when we have decided to experiment with a more rational allocation of funding, surprise, it seems to work. So as people, I'm sure, are aware, there's been a lot of effort to change the bias of Medicaid from an institutional bias to a community bias. And in this study of 25 states that were starting to pay for home and community-based long-term services and supports instead of incenting people to go into nursing homes, not only, as you can imagine, was this much more acceptable to patients and families, but it was a tiny fraction of the cost of putting people in nursing homes. And even worse, in the sequester, we cut the federal budget for Meals on Wheels by 50%, has still not been restored. In Detroit, the waiting list for Meals on Wheels is 6 months. 6 months, might as well not have it, right? People are hungry. That's why they're sick. You can get your ventricular assist device, but not dinner. So this study found that if we increased by only 1% the number of older persons who got Meals on Wheels, it would prevent nearly 1,800 people from needing to be put in a nursing home. I mean, where is the literacy problem here? All right, listening to patients. So what is palliative care? Bernie defined it. I think what I want you to see on this definition is that it does not once mention prognosis, end-of-life care, death and dying. It is focused on need, not prognosis. Mr. B is still not dead. He's doing okay with the supports that are in place. He is not dying. He would not be hospice eligible. Is he benefiting from palliative care? Enormously. As long as we stick to prognostic criteria, we are missing the boat. So it's moving from the above graphic to the below graphic, where palliative care is done at the same time as disease treatment, not what we do when there's nothing more that we can do. And this is actually the better graphic because the sine wave is much more typical of people like Mr. B. Crisis, stable, crisis, stable, crisis, stable. The data on palliative care are very clear that it both improves quality on the left in the numerator, and as a result of improving quality, remember Mr. B, markedly reduces spending. Not because it's rationing, not because it's withholding holding things that people need, but because it's preventing preventable crises and meeting people's needs where they are. I think, Tom, are you going to discuss Jen Temmel's data? I'm going to skip this. This is an article from the New Yorker on nursing home palliative care comfort matters. It's a fantastic article. I commend it to you. It was in their innovation issue in May of 2013, The Sense of an Ending, where in this nursing home, the focus of care is what the patient or the resident says they need, as opposed to their own schedule and regulatory requirements. This is an RCT of Kaiser showing that if you randomly assign sick people to get home palliative care versus Medicare, home health care, that they get a lot more home visits, but a tiny fraction of hospitalization, doctor's visits, nursing home visits. In other words, if you do what Mr. and Mrs. B are getting, you save yourself a ton of money. Now, Kaiser can see this because they one system and they can see where their spending is. The rest of us have much more difficulty. These are the 5 key characteristics of effective palliative care: targeting, asking people what matters to them, supporting families, expert pain and symptom management, and 24/7 management. So I want to get to the literacy part, the goal setting. What is most important to you? And I wanted to tell 4 patient stories. I'm not sure I'm going to be allowed to do it, but I'm going to try anyway. So these are all actual patients that I was involved in the care of. Mr. R was a 67-year-old Latino man that I met on the palliative care service after 4 months on a ventilator in the hospital. Trached, pegged, not able to communicate, no family visitors at all. When the house staff tried to talk to him about did he want to stop this and die, because that was the only option, he always said no, he didn't want to die. But nobody got behind that, right? So finally they called us 4 months into the hospital stay, and one of our staff who is fluent in Spanish asked him about his family and got him one of those speaker valves so he could talk a little bit. And he just kept saying, mi hijo, my son, my son. We didn't know he had a son. We didn't know he had anybody. So our social worker did a huge amount of research and found his son, who was in Chicago, and we paid his way to come and visit his father. And the son told us that the father was, terribly abusive to him, his siblings, and that none of them had seen him in decades. But he came. He came, and the father asked forgiveness. And the son gave forgiveness. And then he left, and then the patient died on his own without our help the next day. Where's the illiteracy here? Mr. W was a 44-year-old with AIDS encephalopathy, also vent and TPN dependent, and unresponsive. Had been unresponsive for quite a long time. Always had his mother and his sister at his bedside. House staff very angry. Why are they doing this? Why are they insisting on this? This is abusive. He's suffering. I was rounding on the weekend and went and sat down with the mother and the sister and asked what they were hoping to accomplish. And that's all I asked. You know, tell me about your son, brother, and turns out that what they were hoping to accomplish was to fatten him up so that the open coffin would not make obvious to everyone that he had died of AIDS. Very logical, right? Completely logical. That if enough calories went in, he would be restored to what, because he was very wasted, had terrible muscle wasting. No one in the faith community knew he had AIDS. It was a secret. The open coffin was mandatory. So that's what they were hoping for. So when I explained that this was not going to accomplish that and that the funeral home could do a lot to restore him to himself, they stopped all of it, and he died the following Monday. Mrs. P was a Greek first-generation immigrant who ran a hot dog stand in Central Park, had a witnessed cardiac arrest in Central Park, was resuscitated by a bystander, but had very severe anoxic encephalopathy, never woke up, but was not brain dead, was on a ventilator, a feeding tube, was in the hospital 6 months on the ventilator and the feeding tube, had 3 adult children who frequently came to blows in the intensive care unit and had to be escorted out by security. The youngest child, Sophia, was at the bedside every day and brought her 6-year-old after school to sleep on a hard plastic chair next to the mother's bed every evening. We got called 6 months into the stay and were told that this daughter was abusive to the child because she was making him sleep on the hard plastic chair, and was abusive to her mother, who had the worst pressure ulcers anyone had ever seen, right? So we sat down, the nurse I worked with, Cheryl, and I sat down with Sophia, and Cheryl said, tell us about your family. And outpoured this incredible story of abuse, child abuse, by this mother. Kids had no shoes in winter, had no winter coats, were beaten, were starved, were screamed at. So all of a sudden the behavior makes perfect sense, right? The house staff are saying, your mother is suffering, why are you doing this to her? Well, that's the culture of that family. Suffering is what we do. We do this to each other. And why don't you just let her die? All they had wanted to do was kill her through much of their lives, so they couldn't act on that impulse, right? As soon as she became conscious of that story, because we had asked the open-ended question, she agreed to take her mother off the ventilator. But nobody had asked, what's the backstory? And Jenny, who I wrote about in Health Affairs with her permission and her family's permission last year. And just very briefly, the title of the article, I Don't Want Jenny to Think I'm Abandoning Her, was an oncologist's response to my question about what he hoped to accomplish with intrathecal chemotherapy for somebody with metastatic non-small cell lung cancer to the brain. That's Jenny. I took care of her along with him for 2 years. We worked together because she knew the oncologist could not talk to her about what would happen if things stopped working, and she was a psychologist and really wanted to know. That's her daughter, Sarah. When, towards the end of her life, the oncologist offered intrathecal chemotherapy, Jenny called me and asked what I thought, and I controlled myself and said, you know, I'm really not familiar with this treatment for this situation. I'll call Dr. C and one of us will get back to you. I asked him what he was hoping to accomplish with this procedure. He immediately responded, it won't help her, which is what I suspected, but wasn't sure he was going to say that. And there was a long, awkward pause on the phone. Remembering that I was the consultant and not the primary, I said, do you want me to encourage her to go ahead with it anyway? Very long pause. And he said, I don't want Jenny to think I'm abandoning her. Where's the literacy problem here? This oncologist did not know any other way of showing his care and love for his patient other than to give her intrathecal chemotherapy, because his training included nothing about accompanying patients when chemotherapy no longer helps. And that's Jenny and Sarah and George on one of the many trips to Europe that their oncologist made possible. So I'm very grateful to that oncologist, because he taught me more than I ever had understood before about what motivates my colleagues when they do things that don't make sense to me. And it's love. It's not venality. It's not greed. It's not indifference. So Jenny did go home with hospice. When I visited her at home, I asked her how she was feeling inside herself, and all she wanted to talk about was the fact that her oncologist had neither called nor visited since she was on hospice, and how hurt she was and how she couldn't understand it. And with her permission, I called him and said that she wanted to see him, and he said, why? Isn't she home on hospice? There's nothing I can do for her. And he was angry. There's nothing I can do for her. And I said, she really wants to see you, to say thank you, and to say goodbye. She's very grateful to you. And he went to the house, and she did that. And she died a couple days later, and I saw him at her funeral. So literacy, the question of what is most important, this is a study of older people in a senior center when asked what was most important between living longer, having relief of symptoms, or remaining independent. 76% put remaining independent as their #1 priority, followed by pain and symptom relief, followed by staying alive. How is the healthcare system designed? Just the flip, right? Just the flip. Family caregivers, 47 billion hours of unpaid work per year, skilled care like Mrs. B is providing, very high risk of death, disease, and personal bankruptcy. Atul Gawande agrees with me. This is the first sentence in his book. I learned about a lot of things at Harvard Medical School, but mortality was not one of them. The New Yorker agrees. There's no easy way I can tell you this, so I'm sending you to someone who can. There is hope. The IOM has been hammering away at this actually for years. There are 8 separate IOM reports calling for better access to palliative care. Maybe finally we're listening. The IOM report that I was privileged to participate in calls for palliative care as standard of care, essentially, for people with serious complex illness. We've got to expand these practices like Mr. and Mrs. B to the home, and we've got to train every oncologist, every cardiologist, every primary care doctor, every nurse in a nursing home in the core principles and practices of palliative care. There will never be enough palliative care specialists to even come close to meeting the needs. Thanks to the American Cancer Society for working really hard to convey this message to the public. This is a series of ads. They paid a very expensive Madison Avenue advertising firm to develop. You can see that cancer becomes dancer, chemotherapy becomes mother. And I'm going to close with another voice from a patient. In the past, we considered ourselves successful when we cured ovarian cancer or myeloma, even though patients lived with terrible consequences of this treatment. So these are quotes from patients with severe neuropathic pain after treatment from ovarian cancer. These quotes are from the 80s, although it was published in early 2000, and you can read these. Very significant suffering and disability as a consequence of treatment. That was then, and this is now.
Neuropathy it's a type of nerve damage. It affected my feet, my hands, and that's how I make my money. So I've been out of work for more than a year and a half.
I met Debbie when she came into the hospital with an acute pain crisis. She was really going through a lot in terms of just living with this new diagnosis, and then to be suffering from symptoms sort of related to the treatments so that she can live with the diagnosis.
With me being in the pain, I just shut myself out and just stayed in my room. The most they saw of me was to come out and get something to eat and go to the bathroom.
She was really crippled by this neuropathy. And you see, she does hair, and that was one of the things that came out when we were in the hospital. You know, sort of what bothers you the most about this pain.
They talk to one another, and they come and they talk to me with each other. Not, you know, they're talking just in a conference among themselves, but they include me in that conference that they're having with one another in terms of the medication I'm on, how I'm treating, how's the medication treating me, how I'm sleeping, how is my quality of life.
I mean, she's such a beautiful person and so lovely and social, and you can imagine for her not to be in that world, it really robs her not just of, you know, financial security, but her identity. And I think it's powerful to think that if you can give her some of that back by controlling her pain, you're really allowing the miracle of her treatment for her myeloma to fully realize itself.
I would not be back sitting in this chair right now if it wasn't for the program. I would be lost without them right now, lost.
She's a perfect example of how palliative care can help.
I feel I'm in the driver's seat because they're really concerned with how I'm feeling.
Thank you, everybody.